So my name is Dr. Kudzai Dombo, and I am a board certified OBGYN who has also had the amazing privilege and opportunity of taking care of women globally. So I have practiced as an OBGYN in Sri Lanka, in Cambodia, in El Salvador, and Haiti, as well as South Africa. And I think the thing that I have found across the board is that in general, culture shapes the way that we perceive our bodies, we perceive what's normal, what's not normal. And I think really what I want to do today, that my deep desire is to really act as a source of education, sharing with you as you traverse midlife, what things may show up, what may occur within our bodies, and when it's important to identify that, I need to probably check in with somebody if these symptoms persist. So what I'm going to talk about, I'm going to start out with, in the space of National Perimenopause Awareness Month, I'm going to talk about perimenopause, and then I'm going to talk about, in conjunction with menopause, and then I'm going to talk about irregular bleeding. I'm going to talk about abnormal pap smears, and I'm also going to talk about IUDs, insertion, and what to expect, when it's inserted, as well as, taken out. So thank you so much for being here, everyone. I'm super excited to get started, and I think I'll just kind of jump in. I have a few notes, so if you see me looking at, paper, just realize that I'm just, I want to stay on track because there's a lot to cover, but I also want to make sure that I respect your time as well. So thank you. All right, so I'm going to start with a few definitions. What is menopause, right? How do we define menopause? And traditionally, we define menopause as 12 months without a period. So from the day that you have your last menstrual period to 12 months later, we consider that 12-month date menopause. And perimenopause, when we think of perimenopause, peri means around. So it's really that time, that natural transition period leading up to menopause, where your ovaries gradually stop producing hormones. And what are the hormones that the ovary produces? We know that the ovary produces estradiol, which is estrogen. The ovary produces progesterone, as well as testosterone and a few other hormones, lesser known, but the main three are estrogen, progesterone, and testosterone. So when we think about perimenopause, like how do we define that? So the 10 years before, so in the United States, the average age of menopause is 51. So 10 years before that is roughly around the time that your body goes through the changes that occur that we define as perimenopause. So it can vary for each person. And it really is a time where you start to experience the symptoms of menopause, or you start noticing that your periods become irregular. And we'll do a deep dive into what irregular means, in a little bit. And I think the thing that is so important that I see that a lot of women find is that, they go to their doctors tell them, oh, your blood work is normal, you're feeling all these things, but, your labs are normal, which can be very deceiving. So I really want to look at not just, your typical symptoms, but also some of the more atypical symptoms, right? They're associated with perimenopause. I think we always think of like hot flashes, night sweats, mood swings, but that doesn't happen in majority of women who are going through this transition. Those are some of the quote unquote, the historical symptoms that, we characterize menopause as. But a lot of women have very different experiences ranging on just what their personal biochemical makeup is and how their body relates to either the fluctuations or the declines in estradiol. Okay, so I'm going to start just doing a deep dive into a few of some of the symptoms that may be not as well known. And then we can also take some questions. What are the mood symptoms that we talk about? Talk about depression, anxiety, irritability, panic attacks. What does that mean? Okay, we know what the word is, but what does that mean for me or you specifically? Let's say you're crying a lot, right? You're going through periods where you're just having episodes where you're just really crying and you're just not really sure, why is this happening? This is not like me. Or you feel a deep sense of hopelessness, or a feeling of like worthlessness. You lose interest in some of the normal activities that you're used to doing. You may start to feel a bit withdrawn, and not want to connect with some of the people that you typically connect with. That can be a symptom or a sign that, hey, it's not just something wrong with you. It just could be your body. And why does this happen? Right? Like, why? So estrogen really supports, the feel-good brain chemicals like your serotonin, your norepinephrine. So that's why it's really responsible for stabilization of your mood. So when you start noticing that, again, in perimenopause, you have these wild fluctuations of estrogen. And then in menopause, you have steep declines in estrogen. So when you start having estrogen levels shifting within your body, you can start to experience some of these symptoms and really are like, man, I'm just not my normal self. What is going on? Again, may have nothing to do with something being wrong with you. It could just be that your body is just going through these changes and your brain is just not able to really stabilize your mood as a result of these fluctuations. So it's worth kind of, if you notice there's been a change for you, it's worth, taking a look and saying, okay, is this connected to my hormones? So, and again, your brain, when it's just left with fewer tools to cope with, you start to experience not being able to cope with stress in a way that you may normally have been able to do. So, that's something to look out for. And then you think about like memory. As long as we're talking about the brain, let's talk about your memory. Like you might start to feel confused, slower thinking. You just feel like you're having difficulty connecting. You go into a room and you're just like, what did I come into this room for? Or you may find that I really thought that I did this particular task and lo and behold, you didn't do it, right? Or you start to feel like, oh, this word is on the tip of my tongue. What is that word again? So, and okay, why does this happen? Why does this happen? So estrogen plays a role in how the brain functions. So all the neurons, the pathways that occur in the brain, estrogen helps in allowing for those connections to occur normally, and also helps new cells and new neurons develop so that your brain works and functions, in a way that you can recognize. So again, when things like that start to happen, it doesn't necessarily mean that, oh my gosh, there's something wrong with me. It really is just your body telling you something about yourself. This is kind of what's happening. So what do I need to do? I know for myself, when that started to happen, I think I started to panic because I started to think, oh my gosh, do I have Alzheimer's? Am I early onset Alzheimer's? Are these things happening to me because there's something actually wrong with my brain? And it can be a very scary time. But again, I think it's just important to recognize that it can be normal and it can be taken care of. It's just a matter of, again, checking with your doctor, determining, okay, can we rule out anything major? And as long as that nothing has been found, we can actually, link it to a cluster or a slew of other symptoms that could be from a change and a shift in your hormones. Are there any questions at all at this point? I'm going to go through a few more symptoms, but from what I've shared so far, if you have any questions, please feel free to drop it in the chat or unmute yourself and just, let me know that you have a question. Okay. All right. Let's look at dental health. That's another area that and especially being somebody who tends to be busy. Okay, I went once this year to get my teeth cleaned. I think that's good. When you start in midlife and your body starts to change, it's really interesting the impact that reduced levels of estradiol or fluctuating levels of estrogen will have on your dental health. And so why? Why is this? So estrogen is known as the hormone that is responsible for maintaining, good bone density. So when that bone density starts to decline and it's specifically on your jawbone, what tends to happen is the area where your tooth connects to the jaw, you're going to experience a shift in the way that your teeth interact with your jawbone once you start to have lower bone density. And so what could that lead to? You ask. You can have tooth sensitivity, you could have gum disease, you can have decay, you can lose teeth. So it's really important to make sure that you are going, twice a year, you are getting deep cleaning, right? We can, really focus on the appearance of our teeth, but more importantly, the health of our teeth is important because, again, hormonal changes can impact our dental health. And one thing I did when I went to my dentist the last time, I asked for my dentist to show me the x-rays from, you know, this visit and compare it to the visits before, just to see if there was any evidence of any kind of lessening in the bone density, of my jaw. And I think it's important to ask these questions of our doctors because it's very easy just to go in and out. Oh, I've done my teeth cleaning. But are there any changes? Are there things that are happening before you get to a point where you are in a situation where you're losing teeth, or you're having intense tooth sensitivity and being unsure of why that's happening. And again, that happened to me. I thought that I had a tooth decay. I went in, I had my teeth cleaned, and boom, all the pain, completely disappeared. So yeah. And the other thing, when we look at the mouth, is that estrogen is responsible for the salivary glands. So in order to produce healthy saliva, or saliva that functions normally, you need adequate levels of estradiol. So what can happen when you experience fluctuations in estrogen or in your or a decline in your estradiol level, you may start to notice that the quality of your saliva changes. This can lead to dry mouth. And then when you have saliva that is not a normal, healthy form, it also can impact the remineralization process of your teeth. So again, leading to tooth decay and other things that can cause harm to your teeth. Another symptom that I kind of wanted to highlight was some allergy symptoms like coughing, nasal congestion. You can have rashes, wheezing, sneezing, itching. Those kinds of symptoms can occur as your hormones fluctuate because there is a connection between the release of histamine from your body and healthy estrogen and progesterone levels. So let's say you have a fluctuation in estradiol and also a reduced production of progesterone. That's going to lead to, again, overfiring of the histamine. You're going to release all these markers, allergy type, reaction markers. And then also progesterone that's produced by the ovary is responsible for the stability of mast cells. And mast cells are the cells in our bodies that are also responsible for regulating our allergic response. So let's say you do have like coughing, sneezing, you check yourself for any infections, everything checks out negatively, but it's a persistent concern. It might be worth, looking at what are some other symptoms that I'm having along with this to see whether or not this could be related to some shifts in your hormones. Let me just see here what else I wanted to just talk about. What are some things that you can do for this? You can use nasal sprays. You can use some of the over-the-counter saline blocks. You can also really look at how can I identify the triggers that could be leading up to, some of these symptoms and try to avoid them. Or you can use some of the over-the-counter remedies, or we can even look at talking about hormonal therapies to try to see if that may help along with some of the other symptoms, not just in isolation, but along with some of the other symptoms. So another unusual or atypical symptom that can occur during, this time are like shock-like symptoms, like shocks in the body, tingling, restless leg type symptoms. These can occur because you have these fluctuations in estradiol and estrogen. So I know for me personally, I know that I remember starting to feel like my legs just seemed to have a brain of their own at night when I was trying to sleep, and I had never experienced that before. And the experience of restless leg when you're trying to sleep is not one that I would say was my favorite because you almost feel like you have absolutely no control, of your legs. And why does this thing happen? Why do we experience these, shock-like feelings, the tingling in our, legs, our arms? What could be the cause of this happening? I mean, the medical term we use for it is paresthesia. Well, estrogen works very closely in connection with the central nervous system. So what tends to happen when the estradiol levels fluctuate during perimenopause and then start to decline during menopause is that you now have misfiring of the communication within your body along your central nervous system. So this is something that can happen, but also there are ways that we can address them. If this is the only symptom you're having, there are things like acupuncture. There are things like looking at, okay, do you have a lot of stimulants in your diet, like caffeine, other drinks that you may be consuming that could be contributing to the overfiring of your central nervous system? Can we look at eliminating, reducing some of those things? But really, it's a symptom to be aware of and know that this can just be a part of the entire hormonal transition that occurs in midlife. But again, it's also important as I share that, making sure that you don't have like a herniated disc, spinal stenosis, all the other conditions. It's also very important that you also get evaluated for that. Let's see, what else did I want to talk about? Just digestive issues, that can happen as your hormones shift and change. It's not unusual or atypical for you to notice that you have things like bloating, constipation. And the reason why this happens, like if you have a reflux, these are some symptoms that can occur during perimenopause. It can typically occur even, let's say you're premenopausal, not perimenopausal, but premenopausal, the 2 weeks before your cycle, you can experience some of these symptoms. And the reason why is because progesterone can contribute to some of these symptoms, but also, let's say you do have declines or fluctuations in estradiol, that is going to also impact your gut motility. So your ability for your gut to move food along can be impacted by these hormonal changes. And that can contribute to some of the symptoms associated with the bloating, the constipation, even diarrhea can be another symptom that you have as a result of these hormonal changes. I wanted to mention that. Muscle pain, joint pain, these are all things that can occur as a result of just your estradiol going down. And again, when estradiol goes down, inflammation goes up, so your cortisol levels go up. As your cortisol levels go up, it can cause muscle tension. Cortisol is the fight or flight marker of the body. So cortisol is the fight or flight marker, or the fight or flight, hormone in our body. And so when estradiol levels go down, cortisol tends to go up, and it causes just a sense of inflammation in our bodies. And with that inflammation, it's not unusual for your muscles to be tight. You have joint discomfort, and really the joint discomfort occurs because the area where your joints come together, there's less lubrication in that area. And because of the decrease in lubrication, like it's going to be stiff and tight. So once we can kind of get the estradiol levels like to a point where, we tend to titrate them according to how your body responds, we can get you to feeling better with hormone replacement, or even trying to see other ways that we can reduce cortisol levels, within the body. I'm going to take some water. So if anybody, again, has any questions, feel free to ask.
I will ask something related to my own conditions because I have endometriosis and I take pills like progestin only pills. And I sometimes wonder the relationship between like estrogen dominance in this condition and what's going to happen with me hormonally after I start having the perimenopause or menopause,
Mhm.
symptoms, and how does this hormonal change work in my
Yeah.
case?
Yeah. I mean, I have a few women who have a history of endometriosis and are perimenopausal, and some who are also postmenopausal. And I think the question that really needs to be addressed is, if you're perimenopausal, is your endometriosis under control? Like, are you having pain? Are you having discomfort? Are you having issues with that? And if so, that's probably what needs to be addressed, because being able to address that with the estradiol and the progesterone, suppressing the endometrial implants, we can also help some of the symptoms that you may having. But a lot of women who are postmenopausal, who do have endometriosis, we really try to, if we do any type of supplementation, we want to make sure that we supplement with a solid amount of progesterone to the estrogen, because we don't want to activate any endometriotic implants. So we really try to balance out the ratios once you're postmenopausal or perimenopausal and you don't have any endometriosis symptoms. There are ways that we can kind of look at how we titrate the dosing of both hormones to reduce any activation of those implants if they're still there. I don't know. Does that
Thank
answer your
you.
question?
Yeah, yeah.
Great.
Thank you.
Okay. All right.
Dr. Dumbo, we have a question on the chat from Judy. If a person is experiencing constipation or diarrhea, what is the best way to combat these issues?
Right. Wait, great question. So I think I would probably need a little bit more information. Like, is it just constipation? Are you still having periods? Is this constipation the week before your period, or is it happening at all times? There's so many different answers to that question, but I think what tends to happen is, I usually try to hone in on looking at, okay, can we look at, diet, number one, and see if we can kind of hone in, balancing out not only addressing the hormonal piece, but also taking a look at your nutrition. The other thing is, I have some patients who really have a lot of bloating, but that's associated with a lot of other symptoms that are associated with menopause. So then for somebody like that, I would recommend, okay, maybe we can take a look at trying to manage it with hormone replacement. But then again, if this is all the time constipation and diarrhea, there's a lot of different things that we can do, like the GI map, the SIBO test, just to make sure that you don't have an underlying gut issue that could be that's unrelated, that could be contributing to this. And some people need all of the above, right? But I think it's a step-wide way to investigate to see what is going to work for you, because what works for you isn't going to work for somebody else. So I hope that answers the question. All right, I'm going to move on to irregular bleeding. Okay, what is irregular bleeding? And I think sometimes as women, it's very easy for us to power through. Like, let's say there's a little change in our periods, we can try to power through and be like, okay, I'm good, I'm fine. And I speak from personal experience as well. But we power through, and then sometimes you may end up in the emergency room because powering through has not served us in ending up with like a blood count that's 5. Meanwhile, 12 is really the normal range. So I really want to do this just to kind of help, us understand what is normal and what's abnormal. And if it is abnormal, what are some things that could be causing it? And what are some things that, we can do to try to alleviate some of the issues that could be behind it? All right. So what is abnormal uterine bleeding? This is bleeding that happens like outside of your normal period. And when we talk about a normal period, as a gynecologist, we always want to know, okay, how old were you when you started having your period? How many days between your cycle? So, do you have, we say 24 to 35 on average is what's considered a normal cycle. And then, so if you're having bleeding every 21 days or every 39 days, we kind of tend to say that may warrant a little bit of investigation. And then we also want to know, like, how many days do you bleed? Do you bleed anywhere between 4 to 7, or is it longer than that? Like sometimes if you bleed for 8, 9, 10 days, okay, let's take a look and see like what could be causing that, because we usually say anything outside of 7 days we consider abnormal. And then bleeding that's not related to your period is also considered abnormal. So let's say in the middle of your cycle, like day 15 to 19, you're having bleeding, and then you have a period again on day 28, that's not considered normal. Or if you have bleeding after sex, that's not considered normal. So what could be the causes of irregular bleeding? Well, it could be just as we talked about, like hormonal imbalances. It could be perimenopause. It could be thyroid conditions. There's certain thyroid conditions that when your thyroid is out of balance, it can cause bleeding issues. So we always want to check thyroid level. Polycystic ovarian syndrome is another condition that we know of that can cause irregular bleeding, more so bleeding where you bleed for like 20 plus days at a time, or you go months without a period. That's the typical characteristic of a PCOS type of irregular bleeding. Then there are other structural causes or structural things within your uterus that can cause like irregular bleeding. So let's say you have a fibroid, let's say you have a polyp, let's say you have adenomyosis. These are things that can actually, like, that are structurally within the uterus that can actually cause it to bleed. Okay. And so that's important for us to evaluate when your bleeding pattern is different. Infections can cause like abnormal bleedings, things like a sexually transmitted disease, gonorrhea, chlamydia, like your cervix being inflamed can cause like abnormal bleeding. Vaginitis, like a vaginal infection, can cause it. A pelvic infection, so having like a pelvic infection, like your uterus having an infection, all these can cause like abnormal bleeding. Certain medications can cause abnormal bleeding. So let's say you're on a blood thinner, you had a blood clot, you're on a blood thinner, that can throw your period off and you can have an irregular bleeding pattern because of that. Precancer or cancer are other things that can actually manifest or show up as irregular bleeding. So that's why it's really important to get it checked out, because again, I've seen patients just be like, I don't have time, I'm busy, and then they end up in the emergency room, where they need a blood transfusion, and it becomes a situation where your options are much less in what we can offer than if we had been able to evaluate and assess and come up with a plan that actually works for you beforehand. So that's what I always tell my patients is, let's really try to see if we can look at things before they've become an issue so that you have the ability to have autonomy of choice over how we actually navigate and manage these conditions. All right, so you come to a gynecologist, you have these bleeding problems. What do we do? First, we get a history, we do a physical exam, and that includes like a speculum exam where we take a speculum, we take a look on the inside, and then we also do a pelvic exam. What tests do? We do a pap smear, we can do a pregnancy test. As I said, we can check your thyroid, do a blood count, maybe check some hormone levels. Those are things that we can do, but also order an ultrasound, right? Just to see if there are any of those structural things we talked about. And we can do an in-office endometrial biopsy, which is a small pipelle that goes through your cervix into the inside lining of your uterus. We get a little bit of tissue, we send it off to the pathologist, and they can tell us whether the area that you're bleeding from, if there's any precancer or cancerous tissue in that area. And that is part of the reason why, it is important to get a full and thorough evaluation, just to make sure that we have ruled out anything that could be taken care of as early as possible. With bleeding, what are some things to look out for? Okay, when is it really like urgent for you to be seen by a doctor? If you start passing blood clots that are the size of a quarter or larger, those are indications that you need to be seen. If you start noticing that you're changing a tampon or a pad like every hour, that is another indication where the amount of bleeding you're having is concerning. Different symptoms of anemia, for example, fatigue, weakness, dizziness, shortness of breath, chest pain, those are all symptoms. Bleeding in between periods, again, for longer than a week, you need to be seen. And then the other thing that I would say is a condition called pica, which is where you have the urge to eat like non-food items. So you want to eat dirt, you want to eat sand, you want to eat hair, you eat, ice. We see this sometimes in pregnancy where women will start craving these these things, and it's just an indication that you're probably very anemic. I'm gonna just break down like what is an abnormal pap smear. So, okay, what is a pap smear? So a pap smear is a screening test that helps us detect changes on the cervix that could be precancerous or cancerous. We want to avoid them transforming to cancer over time. So it's really a screening test, similar to like a mammogram, right? A mammogram will tell you, oh, we see something unusual, but it's really the biopsy that'll tell you whether or not there's an issue. So basically, the pap smear is really a tool to help us detect cervical cancer early, okay? So what is an abnormal pap, right? An abnormal pap is simply a signal for further evaluation. I know it brings up a lot of stress and a lot of angst, but really, truly, and I'm going to delve into HPV as well, because I think there are so many different types of abnormal PAPs. I'm not going to go into all the details, of all of them, because I think the abnormal PAP is just a signal that we need to do further evaluation for something that considered a very treatable condition. So as an OBGYN, we know that 90% of the population that has been sexually active have been exposed to HPV. And one of the tests that's done with the PAP is the HPV test. And why is the HPV test a big piece of the puzzle? I think it's because studies have shown that HPV, especially the high-risk HPV, can be a cause for the progression of abnormal cells to cancer. So that is really with abnormal pap smears why we do them, we evaluate them, and we really have you come back, for further testing, because we want to make sure that we can actually catch cells that have the potential to transform from transforming. Okay. So again, most of the time, patients who have abnormal paps, your body has the ability to fight off HPV. So it's, again, as I said, 90% of people who are sexually active have been exposed to HPV at one point, in life. So it's not something that we get alarmed or concerned by, because it's something that we see very often. However, I think what we want to do is make sure that we're able to pick up any lesions that have the potential, for transforming to either precancer or cancer over time. And that's why we usually, if we pick up an abnormal pap, we have you come in for a test that's either a repeat pap in 6 months, or for another test called a colposcopy. And basically what a colposcopy does is it helps us with a magnifying glass take a look at the cervix, identify any areas that look clearly abnormal, do the biopsy, send it off, and determine what is the next step.
Very good. Thank you, Dr. Dombo. We will now open if our participants have any questions. Feel free to unmute yourself, or you may type in your question through our chat. We have one from Luana. All symptoms associated with perimenopause and menopause can we manage with hormone replacement therapy?
So here's what I tell my patients is that it depends, like not everybody wants hormone replacement therapy. Some patients want to go the more natural route, which is absolutely okay. And it really depends on what symptoms are most bothersome. Some patients have symptoms like inability to sleep that absolutely wreaks havoc with life. And they really need to be able to get back to a good quality of sleep so that they can avoid the depression, the anxiety, the, inability to tolerate stress. So majority of symptoms of perimenopause and menopause can be managed, with hormone replacement therapy. However, I think it's a very individual decision for each person, and I try to meet everybody where they are. I hope that answers your question.
Yes, we have a lot of questions came from our info and some of our patients that left the questions for Anna, and she will be reading them to you. Dr. Lishan, you have any questions? Very good. Hello, welcome, Dr. Lishan.
Hello, everybody. Hi, Dr. Dombo. Thank you so much for all the great information you have been teaching us and answering all the questions that we had in mind. I just have one question. So I have a patient, actually, I was just seeing her before I joined the meeting, who had 2 years ago endometrial thickening and some cysts in there. And she has been on hormones forever, but then I changed her to the Bi-East cream, and she started spotting a few days ago. So I don't know if she was taking something which was not effective before, or the endometrial thickening changed to a thicker layer, or the cysts are affected somehow. What do you think in this situation? Should we just stop the estrogen, continue the progesterone, or do you have... I referred her to you, by the way.
Yeah.
So,
Yeah. Well, one of the things is, especially if she's been on estradiol and she started having the spotting, I mean, it may be, and that the endometrial lining is thickened, it may be worth doing an evaluation, of an endometrial biopsy just to see, hey, what is going on. And then, but it could also be what I found, especially with switching regimens, patients can have spotting that occurs when you switch your regimen from one form of estradiol to another. And that tends to resolve over time. The only thing that I am a bit concerned about with her is just the thickening, in the ultrasound, and the cysts. How old is she?
She's like 57 and she has been menopausal for the 8 years. And the last ultrasound was 2 years ago. So I'm gonna do another one.
Yeah.
And she's gonna see you very
Yeah.
soon.
Yeah, and I would be happy to talk her through, depending on what the ultrasound is, whether or not it needs evaluation, because what we found is, especially African American women, we can't just go by the thickness under 4 millimeters because they have a higher incidence of endometrial cancer. So we always say if they have any bleeding, we recommend the ultrasound in conjunction with an endometrial biopsy, because just in general, they have just a higher incidence than the general population of endometrial cancer. So if she was African American, I would definitely talk to her about having the endometrial biopsy done. If she's not African American, and it depends on what her ultrasound thickness is, because we usually say under 4 millimeters, is what we look at as being considered normal, then we can talk about how we would progress or proceed.
Perfect. Okay, but it's the first thing is to just stop the estrogen for now and continue with progesterone.
Yes, I would do.
Okay. No,
Mhm.
thank you.
Thank you, Dr. Lishan. Dr. Dumbo, we have a question from Stephanie. The most challenging symptoms I have had with perimenopause are mood changes and swings, weight gain around my middle, fatigue, and not feeling like myself. I am taking a small amount of testosterone, which has helped a lot with all of these symptoms. Is there anything that can help with this?
So with all the symptoms or just with the weight gain?
Perhaps all the symptoms that she's having. She's having mood changes, weight gain, fatigue, and not feeling like herself.
Right. So it hasn't helped with weight gain. Got it. And how long have you been on the testosterone, Stephanie? A couple of months. And is your resistance exercise and nutrition been dialed in as well? Like, have you been able to, because that's usually where I start, was with the nutrition, and then your resistance exercise. I try to make sure that, along with hormones, we're doing justice to that. And then if for whatever reason you still find after several months weight is still a huge issue, it really every person's different. Some women are like, I absolutely cannot deal with this weight and I need an alternative plan, to be able to manage. There are some oral medications that can help, but then there are also some other medications that can help with weight gain. Obviously I don't prescribe myself, but some of the Ozempics are there. But again, I try to look at what is it that is most bothersome. If you already are frustrated and you've been doing your exercise, your nutrition, you've been consistent with that, and you still are not losing the weight, and it's frustrating and it's impacting, your quality of life, we can talk about what are some of the other modalities around weight loss. I know estradiol is not a weight loss drug, but one of the things that I share with patients when it comes to the estradiol is that it can help with that, redistribution. So a lot of times in perimenopause and menopause, you have the tendency to gain weight around the belly area, right? So that's where that unwanted belly, like belly fat is. And so the benefit of estradiol in a regimen is that it helps redistribute the body fat from the area around the belly to other parts of your body, right? So it's not going to be a weight loss drug, but it really just helps that redistribution process. I think, and that's the beauty of being able to, individualize everything, but that it may be worth talking with, the person who prescribes the testosterone to see whether or not you would be a candidate for adding estradiol.
Dr. Dumbo, we have a question from Susan.
Sure.
What about for patients with an IUD who don't get a period? Is it not a good idea to have an IUD during perimenopause since you can't observe menstrual changes?
Oh, I think it's actually a really great idea to have an IUD, especially a hormonal IUD, only because the period irregularities that can occur for some women during perimenopause can be significant. And so if you have a Mirena IUD, you already are eliminating any kind of concern around the menstrual irregularities. However, you may still have the symptoms of menopause, but you just may not have a period. So we always go by symptoms. We always take care of patients and the symptoms that they're having, whether or not they're having regular periods. It just gives us a bit more information when we know what's happening with their periods to measure up along with their symptoms. But it's actually a plus to be able to have a hormonal IUD during that time.
One question, you did mention the teeth issues that can develop and bone density. When should a female start doing bone density scan?
That's a very
When
interesting
it's
question.
is there a too early of an age to start doing that?
So what all the guidelines say is 65. And what I do is I basically ask patients to really like dig into their family history, because one indication or one reason why you can get it earlier is if you have a family history of osteoporosis or osteopenia. So what I tend to do is I code it, for either family history of osteopenia, or look for a code to get it done earlier, because getting it done at 65, you already are going to have osteopenia or osteoporosis at that point in time. It doesn't give you enough time to course correct than if you're earlier on, in your journey. So I tend to write it for a lot of my patients who are either perimenopausal or early menopause.
And here's some questions from the front desk. How long does perimenopause usually last before you start actual menopause?
Yeah. So we say on average, perimenopause can be 10 years, the 10 years before the onset of menopause. So if you know that your mom went through menopause at 45, the chances are that you'll probably have menopause enter menopause the same age. And so 10 years before, you may start to have symptoms.
Thank you, Anna. Hold
Yes.
your questions for now. Dr. Dumbo, we have a few more questions. Before I go to Luana, let's read Judy's. I tune in 8 minutes late. Can you explain what estradiol is and how it corrects certain issues?
Yeah, I would be happy to. So estradiol is one of the hormones produced by the ovary. The three main hormones, there are many more, but the three main hormones that the ovary produce: estradiol, progesterone, and testosterone. So what tends to happen when you enter menopause is your ovary gradually stops producing those hormones. The 10 years before menopause is when you have these wild fluctuations, right, of estradiol and then your progesterone. So you have a fluctuation in the hormone levels, especially estradiol, the 10 years prior to menopause, which can give you some of the symptoms that are consistent with menopause, yet you're still having periods, which is why there's so much confusion, because you have symptoms, you get your labs done, they're all normal, but you're not feeling good. And so again, estradiol is one of the main hormones that the ovary produces that can start to decline as you go through perimenopause and menopause.
Thank you. From Luana, what are the natural nutrition or non-hormonal remedies that can help prepare for menopause and avoid waiting for the symptoms to appear?
It's such a great question, because a lot of lifestyle modifications are important in just, again, navigating your body. For example, like when I think about dry eye, I didn't get to talk about that, but that is one of the other symptoms that can occur where, estrogen is responsible for natural tear production and the quality and the quantity of your tears. So when that starts to get compromised during perimenopause and menopause, you can have this condition called dry eye, and you can feel like shards of glass, redness, irritation, you just can't see. And again, if you're somebody who wears contact lenses chronically, it's really important to start transitioning from that and, giving your eyes a lot of rest, a lot of hydration, making sure that you're using humidifiers if you are on screens for a long time. Just make sure that if you're in dry areas, using a humidifier, screen breaks. There are all these different things like lifestyle modifications that can be done. Exercise is huge when it comes to also like some of the mood changes that can occur. Exercise is, one of the more powerful things for memory, doing puzzles, getting involved in an activity that you've not done before, that really gets your brain starting to think. Nutrition, Oh my goodness, there's so many nutritional things that can be, I actually provide my patients with like a 3-day meal plan, and I look at like a more Mediterranean style diet, but with a focus on like omega-3s. We're looking at for making sure the brain, a lot of fiber in the diet, because you know that your gut is going to be, impacted by the estradiol, the decline in hormone levels. So having fiber and protein, you need that for your muscle mass. Right. So it's important that you are eating, a certain amount of protein, 1 gram per kilogram of your body weight in protein, and how you divide that up throughout the day is important. So, looking at your snacks, are you comprising your snacks of nuts and different things? So I think there's so much that can be done, looking at ways that you can reduce stress through meditation and yoga and all the different things that will help just regulate your nervous system. So, I would just love to sit down with you, Laura, and just be like, let's hash this out. Let's get you a great plan.
Very good.
Because I'm all about that. I ended up in an emergency room because I had a severe episode of dry eye where I thought I was going blind. I thought I had a diabetic. I was like, my blood sugar must be 600 because I couldn't see. But I went to see an ophthalmologist, and she happened to be a female ophthalmologist who was in her midlife. And she basically said, look, hormonal changes can do this. And it was like a light bulb went off. And I was like, why am I discovering it having to go through the emergency room? There's so much education that for us as women who tend to put everybody else first and ourselves last, how can we just look at ways that we can make sure that we're taking care of ourselves?
Very good. Maybe we can have 1 more or 2 questions, Dr. Dombo, from our front desk.
How often should we have our checkups or screenings done for perimenopause? And is there any tests that we should consider?
So I tell every patient, because at the age of 35, it's important to get a sense and an idea of what's happening in your body. Because just like the guidelines tell us 65 is when to start doing bone density scans, that's way too late. And considering that symptoms can start and your body can start going through changes as early as 35 years old, I think it's important that at the very least, you are going in and talking to your OBGYN, your doctor, somebody who's aware of what can occur, and coming up with a plan of, okay, where am I right now? And what can I do to allow for my body to go through this transition in the best way possible, or the most seamless way possible?
I have one more great question. How would I lower my gynecological risks for cancer? And what are the symptoms, if there's any, that I should be watching out for?
So I think when I think of gynecological risks for cancer, for example, ovarian cancer, uterine cancer, cervical cancer, fallopian tube cancer, and there's also obviously breast cancer, I think it's really just making sure that you're going to be checked on a regular basis, because it's so easy to be like, I don't feel like anything's wrong, but you just don't know what's happening in your body. So I think it's just paying attention to what your body is doing, and knowing that if changes do occur, it's better to be on the safer side than on the sorry side, where we're actually having to deal with now catching up with managing a problem versus catching it early. So making sure that you're getting your mammograms, making sure you're getting your pap smears done, making sure that you have a pelvic exam. I know you may not necessarily get a pap smear like every year now, but at the very least, getting a bimanual exam so your gynecologist can actually feel for your uterus, feel for your ovaries feel normal, what is going on the inside, so that we can assess, where things are, if there's anything unusual, if you have any unusual bleeding, if you have any, unusual like irregular symptoms like bloating, constipation. Those are things you can also discuss with your, OBGYN. I think one thing that I've learned, especially from, and this is just a funny story, I was in El Salvador and I was doing a health education talk for teens there. And I remember one of their questions, and they were so serious, they asked was, is it true that if you drink lemon water, like water with fresh lemon, that you can stop your period and you'll be able to swim in the ocean? They really believed it. They really believed that it was true. And my natural question was, okay, well, who's done it and did it actually work? And one person put their hand up, but out of, a room full of people. But I think there's so many things that can kind of swirl and go on about what's normal and what's not normal. And I think it's so important to really listen to our bodies and really listen to, okay, what's going on? Am I in tune with what's happening? And not blow off things because we're just so busy. That would be the thing that I would say. Just love. How do we love our bodies, and really take care of ourselves from a place of power?